deal with it much on the street anymore after that. But one other thing that I noticed that there was a huge link between property crimes and drugs in some form or fashion. So, you know, it was either people breaking into other people's houses to get drugs, or they were breaking into their house to steal their crap, to turn around and sell to get drugs. And if I had to put a number on it, I would say that more than 75% of the calls that we answered were directly related somehow to drugs in some form or fashion. So it was a big deal for us. And I was actually seeing this doctor shopping and the pill mill thing, not really realizing that all of this that John just talked about was going on. We came across multiple people in Kingsport where we would get these anonymous calls on saying, hey, these people are on their way back from Florida, they're going to be at this location, and they're probably going to have stuff on them. So, you know, we very frequently came across people with a pocket full of various prescriptions that had just came back from Florida, and they were stopping in at one of our local places because they were, you know, in Kingsport too. I mean, they're everywhere. At one point, we had a guy that was coming in after hours, like 6 o'clock on, same thing, full parking lot, cash only business. It took a while before all the pharmacies caught on that this one prescriber is probably not legit. And we had some other semi-legit places where they were actually hiring off-duty police officers that we could, you know, come in and work on our off days and get paid, you know, just to sit there for security because of the problems that they anticipated. One other thing that I noticed too is that it is really bad in the whole Appalachia span. And I actually had a conversation with one of the guys that I arrested one night, and he had swallowed a bag of cocaine, and we were having to babysit him at the hospital till he pooped it out. But I had like several hours to talk to this guy, and I was like, what exactly brings you down to this area? Because he's from New York. And he said, there's less police presence down here because the area is widespread. We can sell our stuff down here for a whole lot more than we can sell it up there. So we're trying to figure out why are all these people coming from New York and all these other places, because, you know, we have nightclubs in town that, you know, and all the times there was shootings or stabbings up there, it always involved somebody that was from out of state, New York. And I feel like that may be one reason why they're down here, and there's some truth to that. But you know, it's still a big business. I think just within the last week, there was an article that they seized enough fentanyl to make 32 million people overdose in New York. Street value of $30 million, and this was just like last week. So it's not going away anytime soon. But you know, going into medical school and then transitioning out into rotations, my very first rotation was neurology. But what I found out when I got there, this was more or less a half neurology, half Suboxone clinic rotation. So the last place that you would ever imagine being at, this was, you know, Suboxone. And I asked the neurologist, because I mean, he's an excellent physician, and I don't think that he had any ill intention by doing this, but I said, why are you doing Suboxone at a neurology office? And he said, the federal government has reimbursed us a certain amount for EMGs, or their only procedure that they really had. And they all of a sudden have cut the rate by 40%. So we can't keep our doors open with outpatient neurology. So he said, it's not like I want to be doing this, but we had to find something to help keep our doors open. And you know, it seemed to me like of all of the places, they had a little bit more of a legitimate business practice, but still interesting nonetheless. You may run into this in rotations that you would not anticipate having this. So some of the obstacles I think that you're going to see when you get on rotations is that at one point in time, the American Pain Society and probably other places kind of really pushed this thing, and you may have heard this term called pain as the fifth vital sign. You know, the Joint Commission went along with this for a long time, and just recently, I think, tried to back out of their saying that they didn't really have anything to do with this. But you're going to see that satisfaction surveys, which play into physician reimbursement and hospital reimbursement, still ask about pain management. So if someone comes to the emergency department and they don't think that I adequately treated their pain, they're going to fill out a survey at the end of it. You know, they're going to get mailed to them, and we're going to get dinged because we're trying to, you know, practice safe prescribing habits, and it may not have been what they wanted. But whenever you realize that your paycheck and the way you feed your family is indirectly tied to this, it's going to make you think twice about it. And every specialty has their flavor. I mean, we have Press Ganey in the emergency department, but the inpatient folks have HCAPs. Within the last few weeks, I've heard some rumor about HCAPs possibly at least modifying or removing the section about their pain control in there because they're realizing that this is a big problem. But you know, I think that inherently we're probably not that good at determining someone's pain level. I think we are, but you know, you're going to run into a lot of different personality types. You're going to have these old stoic 80-something-year-old folks who they wouldn't tell you they were in pain if they were, because that's their generation. They didn't complain. You know, just like when you're pressing on their belly, you know, you can't take a non-tender 80-year-old's belly as anything at all, because old belly is bad. Is kind of the way that we're trained. So, and then you are going to have other people that are on the opposite end of the spectrum, and you come in and ask them, "What's your pain level?" And they say 10 out of 10, and they're texting on their cell phone. You know, I mean, I have a, you know, it's sometimes hard to really discern where people are really at. So you're going to run into that, and if you couple that with, I think that most of us probably have a caring nature. That's why we went into medicine, and we want to believe people. You know, and I think that even more so in a primary care aspect, I mean, you go into primary care probably because you want to develop long-lasting relationships, and you feel like that you can, you know, trust your patients and they really open up to you, when all the while you may not know. I mean, they may not be doing things themselves, but they may have family members that are taking their stuff, or they just may not be honest with you, who knows. But I think that's one of the things to think about too. But a couple of things that I'm noticing is what's happening from, I guess, more of an emergency medicine standpoint is it's a huge consumption of resources. In Johnstown, we are an old steel town that was probably prominent back in the 60s and 70s. When that industry went, everything went with it. So we are largely depressed area, big heroin epidemic, and we have multiple overdoses that at least make its way to the hospital on a daily basis, not counting the ones that our EMS folks go out on and they refuse to come after they're revived. So it takes a lot of resources, and you know, it takes care away from the people that are at the emergency department for other types of things as well. And you know, we're already understaffed, under budgeted, and that's just the way things are going as we're trying to find ways to, you know, cut healthcare dollars. But what's happened with the EMS staff is they've actually become pretty apathetic to it, because you know, you would really think that seeing a dead 20-year-old would really, you know, put something in your mind like, hey, this is really, there's something going on here and this is not right. But when you have 2 or 3 of them a week, it kind of changes your things, and you're like, it's just another overdose. And it goes across the EMS folks, the police folks. I mean, if you can't blame them, and they get tired of going out on these calls, and where, you know, and they don't come out as an overdose, they come out as a cardiac arrest, they come out as an unconscious person, so they don't know what they're going to. It's an unsafe environment. Our EMS, at least 2 of our agencies up there now are wearing ballistic vests whenever they go on calls, because the violence against healthcare workers is actually increasing now. Before it was, we thought, well, maybe that they're just being mistaken for police, but I don't really think that's the case at all. After seeing just a couple of, within the last month, the doctor in Indiana that was killed for refusing to prescribe opioids to his wife. So you're seeing more and more violence against healthcare workers, and I think you all need to be cognizant of that as well. If you're interviewing a patient and you get some type of sense that if they see you as a barrier to possibly getting what they want, you need to think about that. And just, you know, the part about not being judgmental. I mean, even if you are going to be judgmental, don't do it with your body language or anything else, or how you talk to these folks, because it can be dangerous. So just think about that whenever you're interviewing people. And if you get any kind of weird feeling at all, you probably need to just remove yourself from the situation and grab your attending or resident and let them know what's going on. So, you know, pain medicine physicians are, you know, I really don't envy what they do, because I can only imagine how to deal with you know, this type of thing on a daily basis. We just recently had the pain management physician in Johnstown. He just up and left town. He was there. Everybody loved him. He gave out lots of stuff, and he just up and left. I don't really know why, but we found out on a weekend, because we started having people come in on a Friday night saying that their prescriptions weren't called into the pharmacy, and he basically left them high and dry. And it made it a big problem for us in the ER, because everybody is still going to come to the ER, and we had to try to sort that out as best we could. And we have a new person now that came in, and just preliminarily, he's looking at the prescribing habits of the previous guy, and he's really shaking his head and said that he has a real big mess to clean up. And but it's just interesting because when you talk to the patients, my barber is one of his patients that I just saw before I came down here the other day, and he said, yeah, I really hate that he left, because he said, I'm on my feet all day, I have chronic back pain. He would give me more, than I really needed, just in case I had breakthrough pain. So, I don't really know how this new person's going to be. So I just think it's interesting because it's not just the people that you would think of are just addicted to it. These are regular, middle-class, hardworking people. And their outlook on this guy was he was great, So kind of a conflicting view of the same thing. And the way we look at it, we looked up his prescribing habits just out of curiosity with my ED director. And the previous guy that left town was one of the top prescribers, not only in Pennsylvania, but in the United States as well for OxyContin. So he's now moved over to Danville, Pennsylvania, if any of you happen to go up that way. So we just recently had our PDMP implemented within the last year. Pennsylvania was one of the last few to jump on board with it. And I'm really glad that they did. It's a really good, useful tool for us. Some of the legislation pieces that they put in there, I don't really know if they're going to be as effective as they think they will, because one of the big pieces of the legislation is that they really wanted to put limits on the ER docs prescribing, which is interesting because we are in the big scheme of things, we prescribe a very small amount of the opioids that are on the street. Basically mine's kidney stones and broken bones. I think that by them limiting us, that's fine. And I really don't disagree with what they did. We're limited to 7 days now, which I never prescribed that much anyway. I haven't written an outpatient opioid prescription in months now. But the ones that I saw the most, primary care, pain management, and it was already mentioned before, post-op surgical pain. My first rotation as a resident was trauma surgery. On the weekends, we have to round like them and function as a surgery intern. So I would be discharging all of these people that came in for cholecystectomies or whatever trauma, ankle repairs, and they would say, "Oh yeah, just give them 240 oxy IRs." And I didn't feel good about it, but at the end of the day, it wasn't my DEA, and it was the attending's patient. So you're going to get put into these situations where you may end up prescribing these, not really necessarily because you want to. But I just thought that was the biggest, point where I've actually prescribed more. Really not me wanting to, but sometimes you have to go along with it. So, and a couple of other things. Sometimes when the patients come in and they overdose, they get revived in the field, or we revive them in the emergency department. They wake up. We try to get them to stay at least long enough to where we can monitor them to make sure that whatever they took isn't, still in their system enough to where they're just going to go and have another respiratory depression. So usually they sign out AMA. I think the last one that I had, we had these drug and alcohol counseling things that we can give to people as they're leaving AMA, and he said, "I'll be honest with you, if you just want to save that," he said, "I'm just going to throw it away whenever you give it to me." So you're going to run into the fact that although we want to do our best to help people, and we should, you're going to have patients that aren't ready to help themselves, and you can tell them, but we may not get the response that we want from them. So I'll just be cognizant of that also. Just a little bit about Narcan. Narcan is over the counter now in Pennsylvania. I don't really know if we've seen any difference in the number of overdoses since it's gone over the counter. Our police officers are carrying it now as well, but they're, and it does save a lot of lives, but some of the downsides that we've noticed so far with Narcan are, one, I think that maybe to some people it actually encourages more use, because if they have a buddy that has Narcan with them, they know that, if they take a little too much, they've got somebody there with them that can kind of revive them, and that works to a point. Except for whenever both people are doing it, and you have a situation where a 3-month-old dies in their baby rocker because dad is slumped over in the bathroom and mom is slumped over on the bed dead, and we didn't see it until a couple of days later, until somebody started noticing the smell. So I think that the police carry it, and some of them are unwilling, or I guess not unwilling, but they don't feel comfortable with it. They don't feel like it's their place. And with that, they they get a basic class on how to administer it, but you know, normally they come in 4 milligram vials of the intranasal, so they'll squirt one nostril. You know, they'll wait a minute or so. Oh, they're not waking back up. You know, then they'll squirt the other 4 milligrams up the other nostril, and then they get to the emergency department. And one of the known side effects of Narcan, really with too much Narcan, is pulmonary edema. So these people they come into the emergency department, flash pulmonary edema. We have to intubate them, send them up to the ICU. And they take up an ICU bed for several days before we're able to get them extubated. So it's not without problems, but it is about, you know, it is quite remarkable whenever you see it. Just be prepared that if you're working an emergency medicine rotation and someone's administered Narcan, just be ready and have your security and plenty of people close by, because it is a on and off. People sometimes get really mad that you took their high away from them and they wake up in an unfamiliar place, and they are going to be quite combative. So you just have to be prepared for that if you do end up using Narcan on somebody. And I think just some of the lasting things are the things I mentioned about the unnecessary deaths. You know, it's not uncommon for us anymore to have the 20-year-olds, or that was a real case, the 3-month-old that our coroner came and shared with us. And it's not just the addict people that you would think of off the top of your head. It's just normal middle-class people. Our neighbors, when we moved in next door, they have a little 8-year-old girl that's good buddies with my kids. They have 2 teenage sons, and it was just the mom there. And we found out through word of mouth, and, you know, just kind of, you know, figuring out that the husband had died about 3 months prior to us moving up there, but we never asked any questions. It's not our place. And we, you know, as we've gotten to know these folks, it turns out he was like a youth minister at a church, and he had a legitimate injury and was on medication, and then subsequently turned to heroin. And so he died of a heroin overdose about 3 months before we moved up there. And so that's my neighbor. She actually is watching a little girl right now that's, I guess it would be her brother's child. The mother of the child went back into rehab 4 days after she had the baby, because she was using as soon as she had the child. So I mean, it's everywhere up there. And there was a Johnstown police officer that was just in the news a few months ago that was in charge of the evidence locker, and he overdosed while he was on duty, and they tried to keep it hush hush for a while, but then it came out. So normal middle class people that are working are going to be touched by this as well. And I guess the last thing is just the comorbidities that go along with it, because you can pretty much guarantee that anybody is on long-term opioids, their gut is not going to work, and they're going to have chronic issues with constipation, which leads to small bowel obstructions and perforations and subsequent surgeries, and, you know, more reasons to have pain down the road. And then the illicit drugs or the synthetic drugs that people are injecting, they're going to come in with the abscesses on their hands. You're going to have 20-year-olds with endocarditis that end up getting valve replacements. I was on infectious disease rotation in Kingsport, and we had a patient that was 20-something years old and was back in the hospital after getting a aortic valve replacement. He was back in with endocarditis for the second time 1 year later, and the cardiothoracic surgeons there said, "No, sorry, we gave you one chance. We're not going to operate on you again." And his mother was, frantic and basically calling up every tertiary referral center on the East Coast, seeing if somebody would be willing to replace his heart valve for him. And it's an unfortunate situation, but I guess you can kind of understand where they're coming from also. But like it's been said before, you all are coming up on the forefront. We need lots of young, fresh ideas because it's not going to go away anytime soon. And I think that this really will hit home to you and realize how big of a problem it is if you can see the statistics comparing it to the deaths from World War II. I kind of equate this to like everybody probably remembers where they were at whenever 9/11 happened. I was in high school, and we stopped teaching class for the rest of the day, and we were just watching it on the TV. but some people were still talking and just kind of cutting up and giggling, and our history professor said that you all realize this is worse than Pearl Harbor, don't you? And so I think that was the point where I realized that, oh, this is actually really bad. So I think if you can go into your rotations knowing that this is probably the epidemic of your career, and just being cognizant of it will at least put you ahead of a lot of people that probably will go into it with no idea. So that's mainly what I have for you all. I'm happy to help anybody. We love having students up in Johnstown. We have lots of residencies up there, and we really like DCOM folks coming to rotate. So, but I'll be here all day if anybody would like to chat about anything else later. So, thank you all.